Okay, hello, everyone. We're going to get started in just a few minutes. I just want to wait for more people to join us. Can someone just let me know in the chat that you can hear us perfectly? Okay, perfect. Thank you, April. Excellent. We've got more people joining. I'm just going to wait a few more minutes
Okay, sounds good.
so that everyone has a chance to log in, and then we'll get started.
Mhm.
Okay, I'm going to go ahead and get started with our introductions. Good afternoon. My name is Wendy Brunetto, and I am the Manager of Population Health here at Yale Health. We are here today with Dr. Joanne Knudsen, who is the Chief of Obstetrics and Gynecology at Yale Health, and our speaker, Dr. Liva Andreeva, who is an Associate Professor of Clinical Radiology and Biomedical Imaging and Breast Imaging Fellowship Program Director with Radiology and Biomedical Imaging, Dr. Andreeva graduated from Yale University in 1996 and received her medical degree from Albany Medical College in 2000. She completed an internship at the Hospital of St. Raphael in New Haven, Connecticut, a diagnostic radiology residency at Bay State Medical Center in Springfield, Massachusetts, and returned to Yale University to complete her fellowship in breast imaging. Dr. Andreeva has been a diagnostic radiology faculty member at Yale and is passionate about resident and fellow education, as well as educating the community about the benefits of undergoing breast cancer screening. So during this session, you will learn about the benefits of screening mammography, the updated United States Preventative Services Task Force recommendations regarding screening, and screening of high-risk patients, as well as rates of breast cancer by age, ethnicity, and social determinants of breast health. What we'll do is we'll do our presentation followed by a Q&A afterwards. So please use the chat feature to type in your questions, and I will monitor those throughout the presentation, and we'll get to that after. Okay, welcome aboard, everybody. Hi, Dr. Andreeva. I'm going to turn it over to you now.
Sounds good. Thank you so much for having me again. I will be talking about screening for breast cancer, as Wendy said. So we'll launch right into it. Sorry, objectives. So we'll review some breast cancer facts. We'll look at breast cancer risk in women across different age groups and racial backgrounds. We'll review the USPFT and ACR screening recommendations. We'll look at what tools we have for screening, and also we'll look at screening of patients at elevated risk of breast cancer. So breast cancer still remains a major worldwide health problem, and many of you have heard in the United States, 1 in 8 women will develop breast cancer during her lifetime. And in 2024, about 100,000 women will be diagnosed with breast cancer in the United States. About 2,800 men will be diagnosed. Of course, a man's lifetime risk of breast cancer is much lower than a woman's. It's about 1 in 833, but we do see this as well. Breast cancer is the most common non-skin cancer found in women, and it is the second leading cause of death for women. Cancer death, with lung cancer still being first. In 2023, about 43,000 women died from breast cancer. So what are the most significant risks of breast cancer? So 2 of them we can't do much about. If you're a woman and you're getting older, which is all of us, you are at increased risk of breast cancer. About 85% of breast cancer occurs in women with no significant family history of breast cancer. That's something important to keep in mind. Only about 10% of breast cancers diagnosed are actually linked to genetic mutations. So what is the average American woman's risk of being diagnosed with breast cancer at different ages? So at age 30, it's pretty low still, about 1 in 204. Age 40, it goes up quite a bit to 1 in 65. And then it progressively goes up until age 70. It's about 1 in 24, and potentially further increases as women get even older. And below age 30, it is quite rare. Another thing to note is that the incidence of breast cancer in women aged 40 to 49 has increased noticeably between 2015 and 2019. So more younger women are getting breast cancer than ever. We'll talk a bit about racial discrepancies in breast cancer incidence, which are significant. So non-Hispanic white women have the highest incidence of breast cancer over their lifetimes. So about 136 women per 100,000 women. Non-Hispanic Black women have the second highest incidence rate of about 128 women per 100,000 women. White women between ages of 60 and 84 have a markedly higher incidence of breast cancer compared to Black women. But typically the type of cancers that women get in this age group tend to be a bit less aggressive than the type of cancers that younger women get. Hispanic women have a lower incidence of breast cancer than non-Hispanic white women. Women of Asian and Pacific Islander origin that are born in the US have a similar incidence of breast cancer compared to white women. It's a little bit different for women who are of Asian and Pacific Islander descent who have emigrated to the US. Those women actually tend to have a lower risk of breast cancer compared to white women. And Native American and Alaskan women also have a lower incidence of breast cancer than white women. However, um, even in the setting of reported equal screening rates, Black women are more likely to be diagnosed with a later stage breast cancer than other racial groups. They're also more likely to be diagnosed with the aggressive type of cancer, which is frequently known as the triple negative breast cancer. And they're also more likely, about 40% more likely to die of breast cancer than white women. Minority women in general, that includes Black, Hispanic, Native American, Pacific Islander, and Asian women under the age of 50, so younger women, are more likely to die of breast cancer compared to white women. They are more likely to be diagnosed with breast cancer compared to white women, and they're also more likely to be diagnosed with advanced stage breast cancer. So Black women are also more likely to be affected by the aggressive triple negative breast cancer, and they're less likely to survive. Why is that? So frequently, Black women have less of an ability to access good healthcare resources. So perhaps they can get to screening, but when it comes to follow-up once they're diagnosed with breast cancer, they may have more difficulty getting the help that they need for various reasons. There is racial and economic residential segregation that from discriminatory housing policies that leads to increased exposure to toxic environments, pollution, for instance, any kind of industrial waste nearby, and also stressful life conditions. And residential segregation alone has been associated with increased risk of triple negative breast cancer and poorer breast cancer specific survival. Also, earlier pregnancy rates and higher parity, so more children born, and lower rates of breastfeeding in African American women have been associated with elevated risk of triple negative aggressive breast cancer. Also, higher rates of obesity and due to lack of access to healthy food and exercise options in many Black women increases their risk of this aggressive type of breast cancer. So what is this triple negative breast cancer? So this is a type of breast cancer that does not have estrogen and progesterone or human epidermal growth factor 2 receptors. It is aggressive compared to the most of the cancers that do have these receptors. It grows quickly, and it is therefore more likely to be diagnosed at a later stage. This is the type of cancer that is sometimes presents as an interval cancer, meaning that it is sometimes not detected by routine screening mammography. The patient may have a screening mammogram, which is normal, and then a few months later, she may have a palpable mass that literally grew between the screening after the screening mammogram was initially normal. It does disproportionately affect Black women as well as carriers of the BRCA and PALB2 mutations, which we'll talk about a bit. It has a poorer prognosis than the estrogen receptor positive and progesterone receptor positive breast cancer. The good news is that it frequently responds very well to neoadjuvant chemotherapy, which is a type of chemotherapy that's administered prior to surgery in order to shrink the tumor to optimize surgical outcomes. Also, earlier pregnancy and multiparity, so more children born, increase the risk of triple negative breast cancers, while decreasing the risk of the estrogen and receptor and progesterone receptor positive breast cancers. However, if a woman breastfeeds, this does mitigate the risk of this triple negative breast cancer. So we'll talk a little bit about clues that hereditary breast cancer may be present. So if a woman has ovarian or fallopian tube cancer at any age, she may have a genetic mutation, Also, if she has a breast cancer that's diagnosed at 50 years of age or before, so younger onset of breast cancer. If she has bilateral breast cancer at any age, male breast cancer, so let's say you have a father or brother with breast cancer, first degree relative, if you're diagnosed with a triple negative breast cancer, or breast cancer at any age and Ashkenazi Jewish heritage, or also if you have more than one relative with any of these cancers: breast, ovarian, fallopian tube, prostate, pancreatic, and pancreatic cancer and melanoma. So women with personal history of ovarian cancer should undergo BRCA testing regardless of their family history. We'll talk a bit about genetic mutations that are associated with elevated breast cancer risk. So there are several mutations in some specific genes that are significant, that can cause increased risk of breast cancer. So these are the ones that are, if there's a clinically significant mutation in these genes, these patients have a high risk of developing breast cancer. So these are the BRCA1 and 2. Many of you may have heard of these. The TP53 mutation, also known as Li-Fraumeni syndrome, P10, which is Cowden syndrome, and Banyan-Ruvalcaba-Riley syndrome, cadherin 1, serine threonine kinase 11, which is the Peutz-Jeghers syndrome. And then there are some others that are a bit less, but still significant association with developing breast cancer, such as ATM, PALB2, CHEK2, NBN, BRIP1, and NF1. I know it's an alphabet soup, but so patients that do have a high penetrance genetic mutation, so these BRCA, P10, arguably also PALB2, CHEK2, and ATM, require more robust breast cancer screening. So increased frequency of screening and multimodality screening. So we'll talk a little bit about the harmful BRCA1 mutations. So the BRCA1 gene is located on chromosome 17, and harmful mutations are more likely to be present in Ashkenazi Jewish women, so rather high, 8.3% may have this mutation. Next up is Hispanic women, 3.5%, non-Hispanic white women, 2.2%, Black women, 1.3%, and Asian women have the lowest rate of these mutations. If a patient does have a harmful BRCA1 mutation, her risk of developing breast cancer by age 70 is very high. 55 to 65% of these women will develop breast cancer by age 70. They also have an increased risk of developing a triple negative breast cancer, that aggressive breast cancer that I spoke about. Their risk of developing ovarian cancer is also rather high, 39% by age 70. And they also have an increased risk of developing a second breast cancer after they've had a breast cancer already. BRCA2 mutation, so this is a gene that's located on chromosome 13. And about 45% of these women will develop breast cancer by age 70, so slightly lower. This is also the mutation that is associated about 11 to 17% of these women will develop ovarian cancer by age 70, and they also have an increased risk of developing a second breast cancer. So other conditions that result in elevated risk of breast cancer. So if a woman has a prior history of breast cancer, even without a genetic mutation, she is at elevated risk of developing a second breast cancer. Also, if a woman has had a biopsy that yielded what's called a high-risk lesion, such as atypical ductal hyperplasia, atypical lobular hyperplasia, or lobular carcinoma in situ, she's at elevated risk of breast cancer. Also, if a woman has had radiation to the chest between ages of 10 and 30, so this may occur due to lymphoma treatments, childhood lymphoma. these women are at elevated risk later on in life. Also, extremely dense breast tissue increases a woman's lifetime risk of breast cancer to about twice. So it's a significant independent risk factor. And on that note, I'll just show you what extremely dense breast tissue is. So typically we divide breast tissue into 4 density categories. So you have fatty, scattered fibroglandular, heterogeneously dense, and extremely dense. So women in this category appear to have an increased risk of breast cancer than women in these lower density categories. So what can we do to lower risk of breast cancer? So maintaining a healthy weight does decrease the risk of breast cancer. Also, maintaining a healthy weight decreases the likelihood of recurrence after treatment in women diagnosed with early breast cancer. A diet rich in fruits, vegetables, whole grains, poultry and fish, and low-fat dairy, minimal added sugar, and minimal alcohol is also associated with lower risk of breast cancer. So the American Cancer Society does recommend reducing consumption of red beef, pork, lamb, bacon, sausage, luncheon meats, hot dogs, and sweets to improve one's diet. A quality diet has been associated with lower levels of circulating inflammatory markers, and these inflammatory markers have been linked to both heart disease as well as cancer. Another issue is that vitamin D, so lower levels of vitamin D in Black women may contribute to increased risk of triple-negative breast cancer. So potentially considering vitamin D supplementation, particularly in Black women, may improve their chances of not getting breast cancer. Now we'll switch gears a little bit. We'll talk about history of breast cancer mortality in the advent of screening mammography. Between 1975 and 1990, breast cancer mortality rates in US women were kind of creeping up. However, since 1990, breast cancer mortality rates have fallen about 1.8 to 3.4% per year. And this is attributed to increased use of screening mammography and also improved treatments for breast cancer. And it appears that since 1989, we've averted a significant number, up to 615,000 breast cancer deaths have been averted due to use of screening mammography as well as improved treatments for breast cancer. So this is kind of a visual. Cancer rates were creeping up a bit, and then screening mammography became recommended to women. About 1989, 1990, the screening recommendations started to be issued, and women started getting screened, and there was now a rather precipitous drop in mortality rates. That being said, many women do not go for mammography regularly. In 2015, just about 65% of US women had had a mammogram within the past 2 years. So there were several trials that proved that breast mammography screening works. I won't go too much into it. Some of the earlier trials showed 24% mortality reduction. These are trials done in the late 60s, 70s, 80s, 90s. One of the largest trials, the Pan-Canadian study, involved a huge number of women, so 2.8 million women. It took place between 1990 and 2009, so a long time interval. And basically they compared breast cancer deaths in women who had screening mammograms compared to those who did not. So what they showed was that average breast cancer mortality reduction among participants was 40%. So 40% of the reduction of mortality in women who got screened compared to women who did not. And also another interesting thing that they showed was that the benefits were sustained across different age groups. So women aged 40 to 49 actually had the greatest benefit, 44% reduction in mortality. But even in the older age groups, so 70 to 79, there was still a significant reduction of mortality of about 35%. So back then, this is how mammograms were read. And they still really worked really well. We used to put these films on these bright backlit boards and look at them with magnifying glasses, and the images were not fabulous, but good enough. But now we, of course, have fancy mammogram machines. We have 3D mammography, also known as tomosynthesis, and we view these exams digitally, so we can enlarge things easily and manipulate the images to improve detection of breast cancer. So how does screening mammography work in finding cancers? So basically, early detection matters. So with screening mammography, we can find cancers that are as small as this P and even smaller. Whereas women who do not screen and who do not perform self-exams are more likely to find cancers about the size of a walnut. Oh, sorry, skipped ahead. Also, there are benefits of screening that are shown to be beyond mortality. So also morbidity reduction. What that means is if breast cancers are found earlier, there is less a need for extensive surgery, chemotherapy, and women do better overall. So there are a few trials that showed this. So this one had almost 1,000 women between ages 40 and 70 plus that were diagnosed with invasive ductal carcinoma, which is a type of breast cancer between 1990 and 2001. Half of them about were screen detected and the other half were clinical breast exam detected. So basically the patient's doctor found this. And the tumors found by screening were about 1.5 centimeters, which is considered small. And the cancers found by clinical breast exam were about twice the size, at about nearly 3 centimeters. So patients with the smaller tumors were more likely to have lymph nodes not involved by cancer at time of diagnosis. They were more likely to be able to have a lumpectomy rather than a mastectomy, and they were also less likely to need chemotherapy. And women in the younger age groups of 40 to 49 really had the most benefits. If they underwent screening mammography at least biennially, that means every 2 years, they were less likely to require a mastectomy, have positive lymph nodes. They were less likely to have larger tumors. So small tumors were detected rather than larger ones. They were also less likely to require chemotherapy. So what happens after a screening mammogram is done? So if you take 1,000 women who undergo screening mammography, um, about 10%, and actually it's less now with tomosynthesis. Now it's about, I would say, 6 to 7%. Will be asked to come back for additional views because something was seen on the screening mammogram. And most of these women, so about 2/3 of the women that are called back, will have some additional imaging and perhaps an ultrasound, and we will find that there is nothing wrong. There was a benign finding, perhaps some overlapping tissue. About a fifth of these women that are called back will be found to have a finding that looks probably benign, meaning that it's likely not cancer, but we want to observe it for 6 months to make sure that it doesn't change in a worrisome way. About 20% of the women will have a finding that requires a biopsy for further evaluation, and about a quarter of the women that were asked to have a breast biopsy will actually be diagnosed of breast cancer. So if one gets called back from screening mammogram, chances are still quite good that there's nothing specifically wrong, that there was just a potential finding that then later turned out to be, either nothing or a probably benign finding. So when should screening occur? So this is where the US PFT recommendations come in, the US Preventive Services Task Force. So new recommendations were issued this year. So instead of having women start screening at 50 or suggesting that they start at 50. Average risk women are now recommended to start screening at 40 up to age 74, and biennial screening, so every 2 years screening is recommended. Again, these are for average risk women. Women age 75 and older, so current evidence insufficient to assess balance of benefits and harms of continued mammographic screening. So we'll talk about this particular situation in a little bit as well. And women with dense breasts, again, there's current evidence not sufficient to assess balance of benefits and harms of supplemental screening, such as using ultrasound and MRI to screen if the mammogram is negative. Again, these recommendations apply to average risk women only. What about women with higher risks? So the American College of Radiology, we have guidelines for screening women that are of higher risk than average. We recommend that all women, especially Black and Ashkenazi Jewish women, have a risk assessment by their physician. A gynecologist can potentially do this, or an internist. So a risk assessment by age 25 to assess whether earlier screening than age 40 is needed. So what happens is the physician uses some models that estimate breast cancer risk, lifetime breast cancer risk, so that can really help determine whether a woman needs earlier screening. So who should begin screening mammography before age 40? So women with increased risk based on genetic mutations, such as the BRCA1 mutation, as well as some of the other high-risk patients, and women with a calculated lifetime risk of 20%, so lifetime risk of breast cancer that's 20% or greater. So this number is frequently assessed with these breast cancer risk predictor models. Supplemental screening with MRI. So these are the new American College of Radiology recommendations. So who should undergo early MRI screening? So between ages of 25 and 40, depending on level of risk. So women who have genetically based increased risk, so including BRCA1 mutation carriers, and as well as the other significant mutations that I mentioned. Also, women who have undergone chest radiation therapy at a young age, so between ages 10 and 30. And also women who have been diagnosed with breast cancer prior to age 50, so young age onset breast cancer, as well as women with personal history of breast cancer and dense breast tissue. So these are patients who should consider having supplemental screening in addition to mammograms, also with MRI. I will show you a few cases. I'm a radiologist, so I like showing images. So this is an 85-year-old patient whose last mammogram was 10 years ago. So she stopped screening at age 75, and she palpated a new mass in her breast and came for screening. And on the edge of this image, you can see, this is the oblique view, this is her breast, and you can see that there is something that has some irregular margins. And on ultrasound, she had a suspicious mass, and it also had a few satellite lesions again around it. And this was a moderately differentiated invasive ductal carcinoma. I was going to show you some images from what tomosynthesis looks like. So this is, hopefully this will work. Yes, I think it's working. Yes. So now with the age of tomosynthesis, this 3D mammography, what it allows us to do is kind of scroll through the breast, kind of multiple levels, so you can see potential abnormalities better than in just regular two-dimensional mammography. Sorry, jumped ahead. I might skip over. Yes, so basically there were trials that demonstrated that 3D mammography is effective, that it does reduce screening recall rates. As I mentioned, with tomosynthesis, we have to call fewer women back. Um, and also we have an increased cancer detection rate. We can see cancers better. Here's an example of a 58-year-old woman who had a mammogram that, so the regular 2D image looks, you know, basically normal, but on her 3D mammography, we found this subtle area where the tissue looks like it's a little bit distorted right here. Hopefully you can see a bit, see if it's kind of pulled in over here. And this was the other view, the craniocaudal view, again, the subtle distortion, something that we can only see with the 3D imaging. And this turned out to be a small invasive carcinoma. This is a woman with very dense breast tissue, so you can see lots of this white breast tissue. That's what it looks like on the mammogram. And again, on the regular 2D mammogram, nothing much to be seen, but on the 3D mammogram, again, we saw this relatively subtle area of distortion. See, again, this tissue is kind of pulled in here. This is the CC view. And again, you can see this distortion a little bit better seen on this view of the breast. So, and this also was a breast cancer. As you may know, when you receive your letter, now you are informed whether you have dense breast tissue or not. And this actually started in 2003 with a Connecticut resident, Nancy Capello, who received a diagnosis of a later stage breast cancer. And she had a negative mammogram just a few months before, and her breast tumor was found on screening ultrasound. So she actually successfully lobbied the state senators so that legislation was introduced for both the informing the patients if they have dense breast tissue and also requiring insurance coverage for whole breast ultrasound for women with dense breasts. And we've been doing screening whole breast ultrasound in women with dense tissue since 2009, when the legislation was first introduced. So this is that statement that you may see in your report if you have dense breast tissue. So you have this statement. If you do not have dense tissue, then you will see this statement. So this is what a non-dense mammogram looks like. It's very easy to see through, fairly easy to detect breast cancers. This is the CC view. Whereas this woman has extremely dense breast tissue. So you can see how a small breast cancer could be hidden in this breast, even with tomosynthesis. This is just a repeat of that slide of the density. So patients may obtain an ultrasound if they have dense breast tissue. You still have to ask your physician or to put in an order so that it can be scheduled together with the screening mammogram. At Yale, we do handheld technologist-performed ultrasound. And there's evidence that it can detect small invasive breast tumors that are tomosynthesis occult, so 3D mammography occult in women with dense tissue. I'll skip over most of this. So again, there were some trials that showed that screening ultrasound works, that it does detect breast cancer that is occult on screening mammography. And I'll show you a case. This is a lady, she was 50 years old, came for her regular screening mammogram. She has kind of borderline dense breast tissue. She has breast implants. This is what a saline breast implant looks like on mammography. And these are the implant displaced views where we push the implant out of the way so we can image the breast tissue better. So this looked pretty normal, but on her screening ultrasound, she had this very small, only about 7 millimeters area that looked abnormal. So we biopsied it, and this is actually was a triple negative breast cancer. So very early found triple negative breast cancer. So she actually did very well with surgery because of the small size. She did not require chemotherapy. Here's another example of a breast cancer that was detected by screening ultrasound. So again, mammography shows dense breast tissue. Mammography looked normal, but on ultrasound, we saw this small, so 6.4 millimeter breast cancer. This is kind of what a typical breast cancer looks. They don't all look like this, but this is a fairly typical look. It is important to know that screening ultrasound does not replace mammography. So if you have dense breast tissue, the screening mammogram is still helpful. We can still see calcifications, we can see distortions. Not all cancers can be seen with ultrasounds. For an early form of breast cancer called DCIS, so ductal carcinoma in situ, which frequently manifests as calcifications, can be completely occult on screening mammography. We can only see it with screening ultrasound, sorry, it can only be seen on mammography. And also, it's very important for us to correlate ultrasound findings with mammography. So these two modalities really help each other for us to make a diagnosis. Here is an example of a lady with very dense breast tissue, and she had these faint calcifications. Here's a close-up, so you can see that there are these kind of irregular looking calcifications behind her nipple. And she actually had a completely normal screening ultrasound. This was not seen on the screening ultrasound, was only seen on the mammogram. And this was a very, very small, just a couple millimeters invasive ductal carcinoma with DCIS. Sometimes mammography can fail to detect breast cancer, particularly in aggressive cancers. So this is an example of a 41-year-old woman who is at high risk. She already had a left mastectomy, and now she has underwent screening mammography, but which was normal. And 7 months later, she presented with a lump. So this is her mammogram 7 months ago. You can see that her tissue is dense. It was normal. She also had a normal screening ultrasound. And this is now, so you can see that there's something developing in this area, which was previously clear, not much going on here. And now all of a sudden there's this mass-like area. And on ultrasound, she had a sizable tumor, about 2 centimeters. And this was a poorly differentiated breast cancer, so an aggressive form of breast cancer that kind of grew very quickly. So it literally grew within a few months. So we'll talk a little bit about breast MRI. We are approaching the end soon. So this was breast MRI was first introduced in the 1980s. So it's functional imaging in addition to an anatomic imaging, so we can get an idea of blood flow within the tumor. It does not use ionizing radiation, no X-rays involved. So basically the idea is that blood vessels within the malignancy tend to be more leaky, and they kind of extravasate the contrast material, leading to abnormal contrast uptake in the tissue that we can see. And typically these cancers manifest as masses or these abnormal patchy areas of enhancement. Pros and cons. So MRI is potentially quite sensitive. It can detect up to 99% of the cancers. But it's not terribly specific, meaning that there's a significant overlap in benign and malignant findings. And potentially you can see some abnormalities that mimic cancer, but when you biopsy it, it is negative. So potential unnecessary quote unquote biopsies can result. It does require injection of a contrast agent. It's gadolinium based. It does take about 20 minutes to acquire. And there is some issues with background enhancement. So normal breast tissue also takes up contrast, and it sometimes can, depending on how it takes up the contrast, there can be this patchy enhancement that can mimic malignancy, or the background enhancement can actually obscure malignant findings. And also you cannot do breast MRI during pregnancy. because the contrast agent crosses the placenta and it can end up in the amniotic sac, and we are not sure if there could be some deleterious effects to the baby. Who should receive screening with breast MRI? I already mentioned this a bit earlier. So patients with greater 20% or greater lifetime risk of breast cancer. Again, so patients that have a genetic predisposition due to mutation, mantle radiation for lymphoma between ages of 10 and 30. Also, personal history of breast cancer and dense breast tissue, or patients diagnosed with early breast cancer, so age 50 or under. Also, patients that have history of these high-risk benign lesions on breast biopsy. So again, atypical ductal hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ. So these women benefit from accessory screening in addition to mammography, also with breast MRI. MRI can help if you so in high-risk patients, we frequently recommend staggered screening, which means that patient gets a mammogram, say, in December, and then an MRI in June. So this increases the likelihood of detecting these aggressive interval cancers. What does it look like? Takes about 20 minutes to acquire, as I mentioned. You do have to lie on your stomach in the superwoman position with the arms up, even though arms down is another option. And this is what it looks like. So sometimes you get a lot of background enhancement, as you can see here, and sometimes you don't. Sometimes you just see, so this obviously, I prefer reading this compared to this. I'll show you a quick case of a woman who was at high risk. She's 60 years old and she has a 27% lifetime risk of breast cancer. Dense but negative mammogram. This is a clip from a previous benign biopsy. So her MRI was actually quite easy to read, not that much background enhancement, but this lit up like a Christmas tree. So there's a mass, kind of, lobulated. These were all, she had previous screenings and these were stable. This is normal background, but this was new. We did what's called a second look or MRI directed ultrasound, and we found a correlate in her right breast, small, about 8 millimeters in size. And we were able to biopsy this using ultrasound, and this was an invasive ductal carcinoma. Basically, I'll go through this quickly. MRI screening of women at high risk does detect additional breast cancers in addition to mammography, so it is beneficial for these women. Future direction. So what is coming? So potentially ultra-fast MRI. So MRI that takes less than 20 minutes, so only about 8 minutes, but still has the ability to detect breast cancers not seen by a mammography. Also, we will hopefully soon have contrast-enhanced mammography at Yale, which is a mammogram that uses contrast so we can see lesions that are otherwise not being able to see. This is a good alternative for patients who cannot have breast MRI for various reasons. And of course, there's also increased use of personalized screening recommendations based on individual risk. Okay. So in conclusion, mammography saves lives, not only due to decreased mortality, but also there's improved life quality if you detect breast cancer early. We recommend starting screening at age 40 for average risk women and continuing annually. It saves the most lives and decreases morbidity of breast cancer treatment. So women at increased risk of breast cancer due to known genetic mutations, family or personal history of breast cancers benefit from supplemental screening with MRI, and women with dense breast tissue benefit from supplemental screening with ultrasound. Thank you. I can't hear you, Wendy. Yeah.
I muted myself. Sorry about that. Okay. This was great. We really are happy that you were able to do this for us. We do have a few questions.
Sure.
if
Mhm.
I think we have some time.
Mhm. Sorry,
Um,
it was long.
no, you did great. It was really informative. What is triple positive breast cancer with a staging of 1? I think she might be frozen
Yes,
temporarily.
you froze. Yes, sorry, or somebody froze. Maybe
That's
me.
okay. What is triple positive breast cancer with a staging of 1?
So that tends to be stage one, that means it's very early. So frequently it's based on size and also whether um, there's any other disease in the breast or the axilla. So I think stage one is basically like 1.5 centimeters or less. And typically when it has the ER/PR positive, that is generally means it's so it has the estrogen and progesterone receptors that tends to have a better prognosis. Um, so yes, so that is a relatively favorable breast cancer kind of.
Is
Yeah.
3D mammography the standard now?
Yes, basically, yes. In most places in Connecticut, and I think it's getting more and more prevalent elsewhere, but it's a standard for us for sure.
Right.
Mhm.
And Dr. Knudsen, I know people don't necessarily need a referral to have their mammogram scheduled, but do they need a referral to have an ultrasound if they have dense breasts?
Oh, hi. Yeah, that was a great talk, Leave. I really enjoyed your
Yeah.
information. So for the Yale Health members, we actually have, well, first of all, I guess I'll go back to the mammogram question. Yeah, so the state of Connecticut wants, women to have access to mammogram screening. So Leva, my understanding is that no one in Connecticut needs to get a referral to get a screening mammogram. So you have
That's
access
correct.
to that, and we honor that at the health plan.
Mhm.
We also
Unless
have,
I
uh,
think under age 40, they might.
oh
Um,
yeah, yeah,
yeah,
yeah.
if it's so for like high risk screening, so women who start screening under 40, I think they do need a referral. Yeah.
Yes, I think you're right. I've entered some of those from my patients. Um, and so as we've mentioned, usually people need a ultrasound order, but at the Yale Health, for our members, we have an arrangement with Yale New Haven Diagnostic Imaging so that if your prior mammogram demonstrated you had dense breast tissue, then the following year you can schedule both. Now they have a lot of schedulers working the phones at Yale Diagnostic Imaging. So sometimes because we're like an exception, the scheduler may not understand that. So they may tell you to call our office and then, so, just give us a call. We'll help facilitate. But in general, and then we do have retirees who have flipped to Aetna Medicare, but we still see them as patients. And that insurance does require the dense breast order. And and I guess I should spread the word. They Our understanding is Medicare is no longer covering the dense breast ultrasound screening any longer.
Yeah, it's unfortunate.
Yeah.
Now, do we screen every 2 years or every year for normal risk women? The last slide said annually.
So actually, yeah, good point. So there are some slightly differing recommendations. So the USPFT recommends every 2 years, but actually, like ACE, American College of Radiology, as well as there's a couple of other, and as Society of Breast Imaging, we do recommend every year. It does appear that if you screen every year, you detect. You're more likely to detect smaller breast cancers, but a biennial screening, so at least every 2 years screening, is pretty close. So that's why, the USPFT takes into consideration many other factors, such as biopsy recommendations, the need for quote unquote negative biopsies that end up sometimes resulting from callbacks that can produce anxiety in patients. So hence the biennial recommendations. But it is pretty good, and it is true that most women of average risk um, probably get as very similar, if not the same, benefit from biennial screening, so every 2 years.
Great. Could you speak to the need for MRI in patients with dense breast tissue and flat epithelial atypia?
So flat epithelial atypia actually is not considered a high risk lesion. I know it has the word atypia in it, which is always confusing. Gotta love the pathologists. They always come up with these things, but it's a benign type of atypia. So it's not considered a high risk lesion. But the dense breast tissue is, so if one has extremely dense breast tissue, so that category D, that does appear to be an independent risk factor for breast cancer. And there is some research that suggests that these women may benefit from screening MRI, perhaps not every year, but possibly like every 3 or 4 years or so.
Great. And do we assume that mammogram stops after 75 years of age, even though one of your samples showed an 83-year-old?
So yes, actually, we do not stop screening at age 75. So it is a bit of a shared decision making. So if a woman at age 75 is relatively healthy, her likelihood of living till age 95 or 100 is actually quite good. So this woman should definitely consider continuing screening, whereas women who have a lifetime has many medical conditions, let's say at age 75, her chance of living another 10 years is lower due to other morbidities, other diseases, she could potentially consider stopping screening. But yes, so basically, older women do benefit from continued screening if they remain in good health, because they do have a chance of potentially having significant mortality and morbidity from breast cancer. So again, if you're in good health, talk to your doctor. And yes, we definitely welcome women of all ages. We have 90-something-year-olds coming for screening, and if they're healthy, why not?
Sure.
So,
thank you. Are the facilities reading mammograms still required to send letters to their screening patients within 30 days after their screening mammogram?
yes, that is a requirement. So you should receive a letter within 30 days. Yes.
And do patients that have surgery for breast cancer still receive sentinel lymph node biopsies for specific cases?
Sorry, patients with breast cancer, do they always receive sentinel?
Do patients that have surgery for breast cancer still
sure.
receive sentinel lymph node biopsies?
So depends on, so it's a case by case basis. So depending on the type of the cancer, not always.
Gotcha.
It's definitely a case by case type of thing. It's much more, treatment is much more individualized now. So.
Thank you. And is it possible that the breast was dense and changed to non-dense in a year? It was described as non-dense in my last mammogram. I reduced about 10% of my body weight.
So sorry, did it go from non-dense to dense?
Can you go from dense one year and then non-dense the next year if you lose weight?
So typically, if you, so there may be two things going on. So weight loss can sometimes result in increased density, but also there could be just sometimes due to menopause, or also just kind of overall involution of the glandular tissue, it is possible to go from, I have seen it definitely from dense to non-dense. I've also seen sometimes going the other way. Sometimes women lose a lot of weight and their breast tissue can actually become more dense as the fat disappears and the tissue gets kind of more consolidated.
Great, thank you. I think that is the end of our Q&A. This was recorded and we will make this available on our webpage, on OBGYN's webpage. So anybody can view it on demand if you would like. But again, everyone really enjoyed this talk, Dr. Andreeva. A lot of praise and kudos to you. So we really appreciate you taking the time.
Thank you for having me. It's a pleasure and
Thank
an
you.
honor.
Yeah, thank you, Leva.
Thank you,
Thank you.
everyone. Have a great afternoon, everyone.
Take care.
Bye.
Bye.
Bye.